Okay, this is part 3 of our medication lecture. So we're going to go into a little bit more about administration. So oral administration, this is the most convenient and common method to administer medication. A drug is given by mouth or PO in solid or liquid form, and absorption of most drugs or most oral drugs is in the small intestine. Some are absorbed in the mouth and stomach. We talked about those sublingual medications that can be absorbed in the mouth. But most of them are going to be absorbed in the small intestine. It's easier for patients to swallow with a glass of water, and water should not be offered if a patient has taken a cough syrup, because it can dilute those beneficial effects of the medication. Advantages of parenteral administration, so they're absorbed more rapidly and more completely than the oral route. And sometimes in medications, it's the only way it can be given. So insulin in most immunizations, insulin can only be given sub-Q, and a lot of immunizations can only be given either IM or sub-Q. I think rotavirus is the only immunization for kids that's given orally. Also, some advantages with certain patients: if they are unconscious, then of course you can't give them anything by mouth. Or if they have a gastric disturbance like nausea, vomiting, you want to avoid giving them medication orally because they likely won't keep it down. As the medical assistant, you're usually responsible for administering those parenteral medications, but it might be administered by the doctor if it's an emergency situation. Just depends on what area you're in. IV administration might be during anaphylaxis or really significant or severe dehydration. Some disadvantages of parenteral administration is that it's painful. A lot of people don't like to get shots or injections. So to minimize that pain, you want to make sure you insert and withdraw that needle quickly and smoothly, and withdraw the needle at the same angle that you inserted it. There's also the possibility of infection. So infection signs and symptoms are redness, pain, swelling, if the patient develops a fever. Usually drainage can accompany an infection, but they may not. That's a pretty small area, so they may not be draining. But really that redness, pain, and swelling is what you're watching for as far as an infection. Injections that are given repeatedly, you would want to make sure that you're rotating sites. Overuse of one site can cause some irritation and tissue damage, and that can affect the absorption of the drug. So you want to make sure that if somebody's coming in weekly for injections, that you're rotating sites. It'll certainly be more comfortable for them. Another reason why documenting the site of administration or the location is important. So recording administration, again, the site. So again, you want to rotate those sites, and it provides a reference point for problems if they develop. Where did you give it? So if they develop some pain in their arm where they got the injection, someone will know where to reference. So you want to make sure during parenteral administration that you use medical asepsis. So the needle and the inside of the syringe must remain sterile. Remember we talked about sterilizing is kind of the most clean you can get on something sterile. It, just reduces that danger of any pathogens or microorganisms entering the patient's body. And you want to make sure you're following OSHA guidelines as far as bloodborne pathogens. You want to make sure that you're protecting yourself with PPE, so wearing gloves is going to be important when you give an injection. And if there's a chance that your needle is no longer sterile, you'll want to change it, or the inside of the syringe. So if you poke yourself with a needle, you're probably going to have to get a whole new setup before you administer it to the patient, because you could have some type of pathogen on your hand that's now contaminated your entire setup. So the parts of the needle, there's the hub that fits onto the top of the syringe, the hub of the needle does. The shaft is the portion of the needle that's inserted into the body tissue, and the lumen is the opening of the shaft of that needle. Oh, yeah, I did. So the point is, of course, the tip of the needle. That's what's sharp. That's what we use to insert into the body tissue. The bevel is the top of the needle. It's slanted, so the point is the tip of that slant. So it can make a narrow slit-like opening into the skin. It can close quickly so that the medication doesn't leak out, and it heals very quickly since it's such a small opening. When you have the bevel, when you look at that, you want to make sure that you have that bevel pointed up is helpful. And there's a picture. You know I like the pictures in your book. So let's... Okay. It's on page 648 of your book. There's pictures of the needles, or a picture, of the needle and then the syringe, and then there's also going to be the needle sizes. So we'll reference that here in this next few slides. Oh yeah, look, there it is, page 48. I did have it written down. Okay. The gauge of the needle. So a gauge can range from an 18 to a 27 gauge needle. That refers to the diameter of the lumen. So as the size of the gauge increases, the diameter decreases. So an 18 gauge needle, even though that's a smaller number than 27, an 18 gauge is a very large needle. Usually they're going to use that if they want to infuse fluids rapidly, or if you're giving someone some blood. 27 is very small. A lot of thick, oily medications, you're going to want to give that with a bigger type lumen, just so it can pass through easier. You're going to meet a lot of resistance if you use a smaller gauge of a needle. A large lumen makes a larger needle track in tissue, so you do want to use the smallest gauge possible so that you're reducing any kind of pain and tissue damage. The length of the needle can range to 3/8 of an inch to 3 inches, and it depends on what type of injection you're giving and the size of the patient. So you want to make sure when you're choosing the length of your needle, it must be longer for an IM injection because you want it to penetrate the muscle. So I don't think in adult patients you would, unless you have a really small elderly female or male patient, you really aren't going to use probably less than a 1-inch needle in length, and you can see that on your book. 1.5 inch is probably most often what you're going to use to give in the buttock, in that dorsal gluteal site. So length of the needle is going to be important. Again, the size of your patient, if they're more obese, you're going to need a longer needle. If they're thinner, you're going to require a shorter needle. A syringe is what we use to insert fluids into the body. It's made of plastic and it's disposable. And the syringe has a needle attached in the packaging. So sometimes that's true, sometimes it's not. But the syringe is usually in some type of cellophane wrapper. So it's like we talked about with the, when you're sterilizing your instruments in the autoclave, it's that paper type material on one side and then the cellophane plastic on the other. Sometimes you have a syringe and a needle. Sometimes the needle's connected to the syringe. Sometimes it's not. Sometimes they're separate. Excuse me. A rigid plastic container is going to be your bigger type syringes where you have like 10, 20, or 30 mLs of a syringe that maybe you want to do during a procedure. On that wrapper will be printed the syringe capacity, so can it hold 3 mLs, can it hold 5, and then the length of the needle if it's in there, so or if it's just the needle by itself in a package. If the needle and the syringe are separate, you'll of course have to attach the syringe to the needle. So the barrel that holds the medication, and it's calibrated so that you can measure the proper amount. Most of those are calibrated in mLs. That's what you're going to see. You're not going to see that cc very much. And usually it's 3 to 5. You might see a 3 ml syringe or a 5 ml syringe. But that barrel holds the medication. The flange, that's the rim at the end of the barrel. That's what helps you hold on to the syringe and inject the medication. And it helps keep the syringe from rolling around when it's placed on a flat surface. The plunger, that's of course what you use to draw the medication in and out of the syringe. You push the plunger to inject the medication into the patient. So types of syringes, again, you're going to choose your syringe based on what medication or what type of injection you're giving. A hypodermic syringe is usually calibrated in milliliters. This is what I was talking about, the 2 to 2.5, 3, and 5 mLs. Those are what we use most often. You're going to see that 3 and 5 most commonly. An insulin syringe is just used for insulin. It's calibrated in units. So it'll be 100 units. It's abbreviated U-100. It can hold 100 units of insulin. Some patients give more than 100, not very often though. But if they're going to give 50 units of insulin, they can give that much in that insulin syringe. It's just calibrated differently. It's calibrated in units instead of milliliters. A tuberculin syringe or a TB syringe, you give a very small dose. So it only holds 1 ml of fluid. And it's used, again, to deliver a very small dose, and it's divided into tenths and 100ths of a milliliter. So usually that tenths marking is what you'll most often use with a TB syringe. Again, you can also get those syringes in 10, 20, 30, 50, and 60 milliliters. We don't use them for medication injection. We use those more for irrigating wounds, for draining joints or cysts. Drawing fluid out of something, not so much for medication. Your safety engineered syringes, so OSHA stipulates that your needles need to have a safety device to reduce needle sticks and sharps injuries in healthcare workers. So employers are required to evaluate and implement safer medical devices. We talked about this in our OSHA talk. But there's a built-in safety feature. It helps reduce, it's a covering to the needle so that no one gets stuck and helps reduce those needle stick injuries. Vials. Vials are a glass container with a rubber stopper. It's usually soft metal or a plastic cap that protects the rubber stopper at the top of the vial. You can see more pictures of what a vial looks like on page 652. Figure 2611 to be exact. So this metal or plastic cap is what I usually see. Under that plastic cap, you just flip it off, and then there's a rubber stopper. And you have to take that cap off, of course, to access the medication. You can get a single dose or a multi-dose vial. A single dose vial is usually going to be like a B12 injection, that Kenalog or Toradol that we talked about earlier. A multi-dose vial, influenza vaccines come in multi-dose, so there's different ones that you can get. You just have to pay attention and make sure you're reading the label carefully. Some vials require some type of mixing or reconstitution of a powder. So you have a vial of some type of solute, and then you have your powdered drug. So you want to make sure that you mix those really well. And you want to do that by rolling the medication between your hands. You don't want to shake it because that can make bubbles that get into the syringe. So when you're removing medication from a vial, you want to inject the amount of air equal to the amount of liquid to be removed. And that prevents a vacuum from forming, which makes it difficult to remove the medication. So if you are going to inject 1 ml of fluid, you're going to take 1 ml of air and inject that into the vial of powder. I'm sorry, my dog is being very loud. So you want to inject 1 ml of air into the vial that has the powder, and then you would inject 1 ml of fluid, if that's the amount of medication that you need, if you need 1 ml of fluid or liquid. So you would inject that 1 ml of air and then into the fluid or liquid. You would take that 1 ml of fluid and then pull it out of the vial and then inject it into the powdered drug. And that's when you would want to roll it and make sure you're not shaking the medication. You want to make sure that you're injecting air above the fluid level. Again, that helps keep air bubbles out of your vial. You want to remove the medication by inserting the needle opening below the fluid level. So when you draw back, you're not drawing air. Again, you're keeping air bubbles out. And you want to make sure that you're drawing up the correct amount of medication. You can remove bubbles that get into the syringe by tapping on the barrel with your fingertips. You'll see some nurses flick the barrel of a syringe. You'll see them use a pin to tap the syringe to get all the air bubbles out. But you don't want air bubbles because it takes up space that medication should be occupying. So it can keep or it can prevent the patient from getting all the medication. Ampules. Ampules are small sealed glass containers that hold a single dose of medication. They have a constriction in the stem or the neck. And there's a picture of an ampule on page 652, again with those vials. You want to make sure there's no medication in the stem of the ampule, so you would tap it lightly as well. There's a colored ring around the neck, and that's where the ampule can be broken. It's pre-scored there to help it open easier. You want to hold on to the ampule firmly with gauze. So you would hold on to the bottom of the ampule with one hand. You'd take your other hand with gauze and you'd break it away from you. The only hazard with this is that small particles can get into that ampule when the stem's broken off. So you always want to use a filter needle when you're withdrawing medication from that. Once you've got your medication out, you can switch to whatever needle you're going to inject the patient with. You don't want the needle to touch the outside of the ampule because then your needle's contaminated and you have to change it out. You never need to inject air into the ampule because the medication can be forced out. So there is So don't touch the outside, very important. Keep your needle clean. You want to insert the needle below the level of fluid and then withdraw the medication. You can actually hold an ampule upside down. There's some surface tension in that ampule, so if you turn it upside down and you have your needle in, it's not going to leak out. You can withdraw your medication from the ampule. You don't see them a lot anymore, but they are used a lot with epinephrine or epi to give during an emergency. Pre-filled syringes. So sometimes medications come in a pre-filled syringe. They're disposable. You don't have to worry about drawing up medication. There's information printed on the syringe, the name of the drug, the dose, and when it expires. So it's very nice when things come pre-filled. You want to make sure you're storing medication properly according to the package insert, because if it's not stored correctly, that it can alter the effectiveness. There are some vaccines that require they're required to be frozen and you have to thaw them out, so making sure that you store them correctly is important. So let's talk about reconstitution of powdered drugs a little bit more. Some medications are only stable for a short period of time. That's why they're reconstituted. And an example of that is the MMR immunization, measles, mumps, and rubella. It must be prepared and stored in powder form. And you add liquid to the powder and reconstitute it. So you have a diluent that's used to reconstitute. It's usually sterile water or normal saline is what is used. Again, you want to add air first to the powder. Add air to the diluent or the liquid, draw up the needed amount of fluid, and then inject that into the powder. Roll it between your hands to mix it. Powdered drugs can be available in single-dose and multi-dose vials, and there's usually instructions on that package insert on how to reconstitute the medication. Like how much diluent to use, how much you're going to give of the medication. Subcutaneous injections, so those consist of injections that are injected into the adipose tissue or fatty tissue located just under the skin. We have subcutaneous tissue all over our body, but there are certain sites that are more commonly used, usually where bones and blood vessels aren't near the surface of our skin. So the commonly used sites are on page 653. Those sites are the upper lateral arms, the anterior thigh, the upper back, and the abdomen. The upper back, let's start the upper lateral parts of the arm. That can be used when you give allergy injections because it's easy to see. So you can evaluate well if they have a reaction. The anterior thigh, you don't see used very much. The upper back can be used again for allergy testing. And then the abdomen is most commonly used for insulin. It can also be used for heparin type injections or blood thinner injections that are given to patients. So when you give a medication via the sub-Q route or subcutaneous route, the medication is absorbed through the capillaries. Remember, those are those little tiny continuations of the arterioles, and they absorb slower than intramuscular. So that's why it's nice to give insulin intramuscular, so it's a nice, slow, constant, steady absorption. You never want to give an injection subcutaneously into tissue that's grossly adipose or hardened. Hardened tissue isn't going to absorb very well, and adipose tissue isn't going to be a good choice either. So you want to avoid those areas. You never want to give any injections into an inflamed or edematous area. It'll interfere with proper absorption. Edematous is swelling, so any swollen areas. Usually you're going to use a 1/2 to a 5/8 inch needle. If you have to use a 5/8 inch, you would use a 45-degree angle or a 90-degree angle with a 1/2 inch. But you're most commonly going to give a sub-Q injection at a 45-degree angle. Let's see. The needle gauge is small. It's 23 to 25. Again, you want to use the proper length so that you're getting into the sub-Q tissue. Elderly and dehydrated patients, they're going to have less sub-Q fat, so in sub-Q tissue, so you're going to want to use a shorter needle. Someone who's obese, you're going to use a longer needle. Subcutaneous tissue is sensitive to irritating solutions and large volumes of medication, so you should never give more than 1 ml. You want to give something that's isotonic. If you remember talking about isotonic solutions, that's like a normal saline. That's what's most similar to our body composition. Non-irritating, any solution that's irritating is going to be painful. You cannot give anything that's viscous, so you want your injection fluid to be non-viscous or not thick. Water soluble is good. Again, no more than 1 ml because it's going to cause a lot of pain and pressure. Epinephrine is given sub-Q. If you think about EpiPens, epinephrine is given sub-Q. That's something that's often given into the thigh by patients who have to self-administer. Insulin again in the abdomen. Allergy injections. Following the injection, the patient is going to need to wait to observe for an allergic reaction. I was thinking it was 30 minutes, not 15 to 20, but I'm sure each site is different. And you're watching for like redness, swelling, itching, any kind of raised area or indurated area. IM injections, intramuscular, are injected right into the muscle. It's located, the muscle layers below that sub-Q layer, and you're going to go in at a 90-degree angle when you give an IM injection. Again, you want to make sure you wear gloves with IM injections because those areas are vascular. And there's a procedure on page 664. It's procedure 26-5. So the IM injections, that's the amount that can be injected. The gluteal and vastus lateralis sites, you can inject up to 3 mLs, and on very thin adults and older patients, up to 2. Your deltoid site, never more than 1 ml. So that gluteal site is going to be the dorsal gluteal site. So on page 655, I guess I supplemented that. 655. Your sites are located on that page. So the dorsal gluteal, which is A, diagram A, that is an area where you can inject up to 3, and the vastus lateralis, which is figure C. Figure B is the deltoid, never more than 1 ml because that's a small muscle. When you give an IM injection, that absorption is going to be more rapid than that you give in the fatty tissue. Medication that's irritating is often given through the IM site, just because there's fewer nerve endings in muscle tissue. Medications, most of the parenteral medications that we're going to give in the office are going to be administered IM. So immunizations, most common. Antibiotics you don't see too often, I guess for me anyway, but it's certainly not out of the ordinary. Injectable contraceptives, we talk about that Depo-Provera that can be given, that's one of them. Vitamin B12, that's an injection for patients who have vitamin B12 deficiency. They can get injections, IM, and corticosteroids. An example of that would be that Kenalog. It's a steroid that's going to help reduce like inflammation, back pain. We can give that to patients with back pain. Somebody who's having some type of allergic reaction, you wouldn't want to give that injection over an area that has hives or anything like that, but certainly that a corticosteroid could be given for that. An immunization that you could give would be hepatitis B. An antibiotic that you might give would be Rocephin, some type of penicillin. Your needle length is going to be 1 to 3 inches. That's longer than the sub-Q needle because you want to hit muscle. The average size is going to probably use a 1.5. On an adult or a thin adult or a child, you might use 1 inch. Obese, you might need 2 to 3. Just depends on their size. Toradol is one for pain that you might give. Your needle gauge range is going to be 18 to 23. Again, it depends on the viscosity or how thick the medication is. Your IM injection sites are located away from large nerves and blood vessels, and you want to make sure that that area is fully exposed. That way you have a clear visualization of the site. The dorsal gluteal, that's our buttock. That's as adults, they're very well developed. They can absorb a large amount of medicine. We want to use that in adults and children over 3. It's best if they can be on their abdomen with their toes pointed inward. That relaxes those muscles. Patients who can't do that, I ask them to stand and bear weight on the opposite leg that I'm going to give the injection. That way their muscle is nice and relaxed. You're going to inject the medication into the upper outer quadrant of the gluteal area. So you're going to palpate the greater trochanter. That is the top of your femur, and the posterior superior iliac spine. And that area is your back. It's kind of like where the dimples of your buttocks are. That dimpled area. You can draw an imaginary line between these 2 points, and then you want to inject above and outside of that area. Method 2, this is my preference, is you divide the buttock, so just the one cheek, into quadrants, and you want to go to the upper outer quadrant. You want to make sure you're about 2 to 3 inches below the iliac crest. The iliac crest is the top of your hip bone. So, and a lot of times you can feel that. Here I am pushing on mine like you can see me, but I like that because you take the top of the butt crack and you go right across, and then you divide that in half, and you're going to go to the upper outer quadrant. It's just always been the way I've done it. I know they don't feel like that's the most accurate, but I feel like that's the best way to do it. It's easy. It's easy landmarks. The reason that they want you to be so careful is because the sciatic nerve and then that superior gluteal artery are in those areas, and you would not want to inject those areas. The sciatic nerve would hurt. The deltoid site, that's the arm, the upper arm. It's very easily accessible. The patient can be sitting. Again, no more than 1 ml in that site. There's no major nerves or blood vessels. There are major blood vessels and nerves around this area. So that's why you can't give a large amount, and you can't give repeated injections there because it is so small. You want to expose the entire arm. I'm never afraid to ask someone to take their arm out of their sleeve because that just gives me a better view of my landmarks. And a tight sleeve can just be restricting and cause more pain. You're going to palpate so the first way you can do that is palpate the lower edge of the acromion process. Remember, that's that bony prominence right here in the top of your shoulder. And it then forms the base of a triangle with a line midpoint of the lateral side of the arm opposite the axilla. So you would just use the area where the axilla is, and you would draw a line across, and it would be in that triangle. I can't show you very well, I'm sorry. But there's a good picture of it to show that triangle in your book. The other way, which is the method I use, is to place your forefingers horizontally across the deltoid muscle with the top finger on the acromion process, and the site is 2 to 3 finger widths below the acromion process, and that's what I use. The vastus lateralis, this is a thick muscle away from nerves and blood vessels. Infants and children younger than 3, this is a great location for them because their gluteal muscles are not well developed yet. So to locate that site, your primary boundary is a hand's breadth below the greater trochanter. So again, the top of your femur, and your distal boundary. So remember, proximal is closest to you, closest in proximity. Your distal boundary is the farthest distance away from you. So proximal boundary is a hand's breadth below the greater trochanter. A distal boundary is a hand's breadth above the knee. And it's bounded by the mid-anterior thigh on the front of the leg and the mid-lateral thigh on the side of the leg. The patient can be sitting. It's easier to do it lying down. I know in some of our peds patients, they're sitting when they get an injection here. The ventrogluteal site. This is becoming more popular. And the reason is because the subcutaneous layer at the site is very small and there's more muscle, more thick, good muscle, and there's not a lot of major nerves and blood vessels. A Z-track method. You will give an injection using a Z-track method for medications that might irritate the subcu tissue or discolor the skin. Iron dextran injections can discolor the skin, so that might be a time when you would use a Z-track method. You can use it for the dorsogluteal, ventrogluteal, or vastus lateralis. You would never use it on the deltoid because it's too small. What you're going to do is when you give that injection, you're going to pull the skin and the subcu tissue to the side. You're going to give the injection and remove the needle, and then you're going to release the skin, and it's going to create a zigzag path through that tissue and seal off the needle track. That way the medication can't leak back into the subcu tissue or to the skin surface and be irritating or discolor the skin. Intradermal injections, so those go into the dermal layer of the skin. Whenever you use your angle to insert this type of injection, it's almost parallel to the skin. The absorption is very slow, so only a very small amount of medication can be injected. You're going to use a TB syringe to do this because you're only going to use 0.01 to 0.2 mLs of medication, so a very small amount. Locations where you might give an ID injection would be the anterior forearm, so right where you get your TB test, which is right here. You might give it in the middle of the back or the upper arm. The needle length is very small, 3/8 to 5/8, and the gauge is 25 to 27, so very small. Again, the TB syringe is used because the calibrations are divided into tenths and hundredths of a milliliter, so you can give a very small amount. The capacity of that TB syringe is only 1 ml. Let me make sure I'm not missing something here. Whenever you give that Z-track method too, you want to make sure you wait about 5 to 10 seconds after you inject the medication, just to let it absorb into that muscle a little bit better. Intradermal injections are used for allergy tests and TB tests like you got before you started class. The medication is injected and a wheal is formed. So a wheal is a small raised area that results as a distension of the skin from the fluid that's been injected. If you have an allergy test, you're going to read and interpret that in about 15 to 20 minutes. If you have a TB test, it's going to be 48 to 72 hours or 2 to 3 days. You also want to make sure that when you give an intradermal injection, you never wipe or cover that area because it can pull away medication or cause medication to run. So you never want to wipe that because it can cause inaccurate results. So if no reaction occurs, the wheal disappears in a short period of time and only the puncture site is a visible sign left. If a positive reaction occurs, you're going to see induration and erythema. So induration is a palpable raised hard area that develops, and erythema is redness. So the only thing that you're really going to monitor is the extent of that induration, not necessarily the redness. That induration is going to be more your criteria for your reaction, and you will measure that induration in milliliters. And that concludes part 3 of our lecture, and get ready for part 4.